Good afternoon, Srinivasan sir.
Yeah. Nice seeing you. Good afternoon.
Sir, sorry, audio come here.
You can hear me now?
Yes, sir.
Yeah. Okay. Old age, so they will be slow when compared to you people. Yeah.
So tremendous energy you have, sir, to attend all the programs.
Yeah. Actually, yeah. I was very busy and luckily I was there in Kumuda's this thing, Mangala Bharati's inaugurating that this thing, LabCon in Chennai, ICH.
Okay.
Where they conducted 8 workshops, all over this So I was given the honor of inaugurating. That was very nice of them. And then I was in Tirupati conducting the 7-day IVCF course before coming to. And then I gave M.K. Nair and Dilip Mukherjee's growth behavior development in Ramachandra, all from 23rd of this thing. So kept busy. Now, Piyush Gupta has given me an assignment of a new model of multiple choice questions in cardiology. So he's given me, I told at this age, there are so many youngsters who have become masters in pediatric. You can give what is it? No, I want you. And he wants in a different setup, with this thing, references and other things. So it takes a lot of time. So I told I'm having 2 orations to give, so it will not be possible to give. I'm in USA also visiting and looking after my grandchildren, their vacation. No, I'm extending the date till October 15th. Only 5 more days are there. So anyhow, keeping myself in academics as far as possible to prevent Alzheimer's disease. And
good afternoon, sir. Good afternoon, Mahesh Murthy, sir.
Hello,
Hi,
Dr.
good
Mahesh.
Good afternoon, sir.
Yeah, last week you were giving unnecessary this thing, comparing me with this thing, Dr. Our KKCTH Bala. I hope he was not offended.
No. I mean, that particular presentation, I was a bit not very happy.
Disappointed.
So somebody had to give a message to them that they need to prepare. You should not take such a senior teachers are there. They should not take it for granted. They should definitely put some extra efforts. That's what's the message.
Yeah, by age I am senior, but knowledge is.
No. Always. You, Bala sir, and Prajapati sir, 3 are there.
Dr. Chetan sir and Rajendra Vaidya sir.
Hello, good evening.
Sir. Hi, Dr. Rajendra. Hi, Dr. Narvada.
Hi.
Major sir.
Hi.
I think
No, I was just listening to
Yes.
Dr. Srinivasan sir just now, and about the.
I wanted to avoid that, so that's why
No.
I tracked.
No, I was just recalling that terminology or word ikagai, and headline of ikagai is never retire. Never retire. To make you 100% beyond 100 years, first and foremost is never retire, and you are the right person. You, Dr. Ambedkar sir.
I'm really there. Today also I went in the morning to Jipmar, so morning, and I was there till like a good postgraduate. I was there till evening. Afternoon, lunchtime I came home.
Great.
Learning is a continuous process, sir. If you want to learn, you can learn from anybody and everyone. Yeah.
Good afternoon, Dr. Kalra.
Carla sir, hello. Carla sir.
Hi, Dr.
Great to
Manas.
have you here.
Manas Karla, sir.
You're mute. You're mute, Dr. Manas.
Yes, sir, I kept myself mute. I was listening to
No.
Pearls of Wisdom by Dr. Srinivasan.
It's always such a pleasure to listen to you, sir.
Always.
And guiding us.
Rajendra,
Oh,
perfect matching.
yes.
Yeah.
Both of you planned for this one?
Yeah. Navratri started, yeah? Navratri started. What is the color today?
महेश मी फक्त
It's
थोडं
4
मध्ये
o'clock.
दुसरीकडे महेश थोडं
Your academic pearls is really brilliant. Yeah.
मला थोडं दुसरीकडे पण जॉईन व्हायचं आहे. हेच सुरू झालं
Academic pearls is so nice. Everybody is now
I think
waiting
it's
for it.
exactly 4 o'clock.
Yes.
Dr. Upendra is at present
Not
flying from Delhi back to Mumbai, so he's not going to join. Maybe he'll join late. He's on the flight at the moment. So good evening, friends, the fellow IAPians, the audience to this program. We are in the 10th month of Academic Pearls 2023. And as you know, we are at present going through the hematology section of our Academic Pearls. And this is every Tuesday program 4 to 5:30. And last time we had a good, nice panel discussion. Today we are going to have a talk by Dr. Manas Kalra. He's from Delhi, and he's going to give a talk on yet another thrilling topic. I think whether you are in the OPD or in the IPD or wherever, one thing we keep talking about stress in the practice. I believe stress usually is of not missing something sinister in the practice. So that if you miss at that point of time, who knows, perhaps next visit could be very disaster. And if I had taken that into account, maybe something I'm all scared of missing is myocarditis, maybe occasional early meningitis, which I may not pick up in an infant or neonate. And perhaps third one, which I'm scared is missing a leukemia. Of course, to some extent depends on me and majority depends on the pathologist. But if I don't send the investigation itself, I will be really landing with a disaster. So here we have an expert, Dr. Manas Kalra. I request Dr. Narmada to introduce the faculty. And he can take over subsequently. Dr. Narmada, please.
Thank you, sir. Today it's a real pleasure for me to introduce Dr. Manas Kalra, who has got a very impressive CV. At present, he's a senior consultant at Sir Gangaram Hospital, New Delhi. He's a gold medalist, not only in MBBS, but also in MD as well as in DNB Peds. He has done his fellowship in pediatric hemato-oncology and 2 years fellowship in pediatric leukemia, neuro-oncology and solid tumors at Westmead, Sydney. And he has got a 1-year fellowship with pediatric bone marrow transplant at the same center. He is the winner of SIOP Young Investigator Award and an author of over 40 papers in pediatric hemato-oncology. He is also the thesis guide for a numerous pediatric DNB pediatric PG, and he has mentored over 30 FNB and IAP PHO students. And previously, he has been the assistant professor at KMC Manipal and also consultant at Apollo Delhi. And he has served as an EB member for IAP North Delhi. We are very happy to have such an esteemed speaker in our midst today. Thank you so much for accepting an invitation, sir. Over to you.
A very good evening to everyone, and I would like to thank IAP for this opportunity to present in the Academic Pearls. So I'll just try to share my screen, which is again something that makes me nervous every time, because suddenly what will happen is that the screen will not share. So it is working right now. So thank you for that.
Everyone.
Now you relax, it's working properly.
Yeah. So thank you for that kind introduction. And my topic is how not to miss cancer in children. And Dr. Mohite has very nicely introduced the topic. I would like to thank Dr. Upendra, Dr. Bastavraj, Dr. Ramesh, Dr. Vineet Saxena, Dr. Mahesh, Dr. Chetan, and all the senior people who have joined here to attend this session on how not to miss cancer in children. So I'll start my talk saying that more than 2 lakh children are diagnosed with cancer every year. And 80% of these live in developing world. And India itself is a home for 75,000 new cancer cases in children every year. And acute leukemia is the commonest of all the cancers. And see this beautiful diagram, which shows the improving outcomes of ALL. Okay, so this is ALL. And if we look at the Western data from 1968 to 2000, you can see that the outcome of ALL is almost touching 90%, more than 90%. Sadly, for developing countries, the cure rates is somewhere around 50 to 60% for ALL. In some of the good centers, you may have outcomes of somewhere around 80% or more than that for children with B-cell acute lymphoblastic leukemia. And the solid tumors somewhere around hovers around 30 to 40%. Now, these figures are much inferior as compared to Western world. How do we improve outcomes of children with cancer? Better supportive care is what is needed for these children. Easy availability of safe blood products, early diagnosis of cancer, increased awareness and improved literacy for patients, parents, even doctor community, risk-based stratification and therapy modification. So you cannot treat every ALL in the same way. There are good ALLs, there are bad ALLs, there are very bad ALLs. There are good neuroblastomas, bad neuroblastomas, and very bad neuroblastomas. You need to treat them differently. And collaborative clinical trials, which now are coming up in a big way, with the INFOG taking a big role in conducting clinical trials in India. What I'm going to focus today is on early diagnosis of cancer. And what is the role of pediatrician when we talk of children with cancer? Early diagnosis is the most important thing, because patients will come to you and only then they will be referred to a pediatric hematologist, oncologist. A timely referral is very crucial for their outcome. We need to allay the anxiety of parents, because most of the children with cancer can be cured. You need to partner with us, rather we need to partner with you. And it has to be a both-way affairs when we talk of managing febrile neutropenia, especially if the patient is away from their oncology center and is in their hometown under your care. Maintenance chemotherapy for leukemia when it is going on, we often need the help of a pediatrician to manage febrile illnesses or other complications that can happen during treatment. And obviously, there is an important role in doing the vaccination post-chemotherapy. Today, the focus is early diagnosis of cancer, and I lead you through few cases and help you to kind of think of cancer whenever you see a patient which is not fitting into the usual common diseases that you say day in and day out in your OPD practice. So first case is a garden variety case where a 4-year-old male presents with fever for 10 days. And by the time he comes to you, he's got big neck nodes, there are petechiae on the skin, there is hepatosplenomegaly. The child has anemia. Often, cancer-associated anemia is normocytic, normochromic, or maybe a little bit macrocytic. There is leukocytosis, and the peripheral smear says so many blasts are there, and there is thrombocytopenia. Now, this is not difficult. You see this report and you refer the patient immediately. The child has B-cell ALL. He's treated for that. He's cured of his cancer, as most of the children are. And he stands first in his class 8 exams. All thanks to you, because you diagnosed, picked this case, referred him immediately. But things are not always that simple. This is a 6-year-old female who has fever of 101 on and off for 3 weeks. Examination did not have any obvious focus of infection. Now, most of our patients are treated with Augmentin or they are treated with cefixime by the time they come to us. Sometimes no culture has been done and the patient has been treated like enteric fever. Hemogram was apparently reported to be normal, but peripheral smear was probably not asked for. Only a CBC was done. That too a machine report, and the pathologist never looked at it. The child is on broad spectrum antibiotics, fever persists. In second week, somebody sends blood culture, treats like enteric, but the patient is not getting better. And by third week, the child is now very irritable, pallor is prominent, lymph nodes are there, there is a 2-centimeter liver and a just palpable spleen. And the hemogram now shows significant anemia, and there are query atypical lymphocytes in the peripheral smear. And you can see the degree of neutropenia. And at this point of time, a bone marrow is done, and the bone marrow shows leukemia. So I would like to emphasize that a lot of children are treated like enteric fever. Before treating like enteric fever, I think it is very important that we send a blood culture. But often in peripheral hospitals, this is not done. We do Vidal on the first or second day. But what is the importance of doing Vidal on the first or second day of fever? It has to be done later in the course of illness. And that too, it is a non-specific test. So we tend to miss leukemias in patients whom we are empirically treating and waiting for a few weeks for the fever to subside. So any child who has PUO, please have cancer in your mind, because cancer is one of the leading causes for pyrexia of unknown origin. A 4-year-old girl presents to you with petechiae, bruises, and epistaxis. This child had low-grade fever for 2 to 3 days. The child reportedly, had mild pallor, and the child cried excessively in the OPD. And because the child was crying, you could not really examine the child properly. Platelet was low. And because ITP is a very common diagnosis, and because 70 to 80% of Indian population is anemic because of nutritional anemia, the pediatrician thinks that this anemia is probably related to nutritional cause, and the thrombocytopenia is related to ITP. and the child is started on oral steroids. Bleeding stops, child is eating well, child is active, child does not go back to physician. Now, this can be a very dangerous situation. And that is what happened in this patient. 3 weeks later, high-grade fever, bruises, marked leukocytosis. You can see the WBC count. Blasts were 30%. And you can see that the platelet was also very, very low. So a low-risk ALL is now converted into high-risk ALL, giving steroids, kind of selects the resistant clones which remain in the blood. And this makes the treatment of leukemia very difficult, and often risk stratification is compromised. And that is one reason why outcomes of leukemia in children in India are inferior as compared to the Western countries. So my request is, do not give steroids in an undiagnosed condition. Do not jump and give steroids in a child with suspected ITP unless you have made sure that many things have been ticked, and I will come to that. And do not give steroids as a transfusion pre-medication. It should be almost avoided in this day and age when packed red blood cells are our choice products for anemia. So what are the indications of bone marrow in such a situation? If there is anemia, leukopenia, please look at the neutrophil count, or there are any other abnormal cell lines. If the child has bone pains, back pains, please do a bone marrow. If there is fever going on, ITP usually doesn't have fever. If you find organomegaly, you need to be on your guard. If somebody reports as an atypical lymphocyte, a non-confident pathologist may just, sometimes call blast as an atypical cell. And atypical lymphocytes are also common in viral infections. So please make sure that you get a good peripheral smear examined. Refer the patient if you are unable to get that. And before giving steroids or a poor follow-up in a patient, please do a bone marrow, like in this patient where the follow-up was not done while treatment for leukemia was going on in this case. I would like to highlight the next case because this is one of the very common presentations of leukemia today. I would say that, ITP and steroids in ITP has now gone down because a lot of education has gone, so many seminars, webinars, and all the time we have talked about not giving steroids just like that to patients with ITP. But I think joint pain is one still a big condition where leukemia is missed. I want to emphasize to everybody that joint pain is a big symptom. Bone pain is a very important symptom of cancer. And please be on the guard when a child complains of joint pains, bone pains, or back pain. Like in this particular child who has been treated for JRA, rheumatic fever, has received aspirin, because the ESR was high, high-grade fever, also thought of septic arthritis. And after a lot of treatment and maybe steroids also, then the child gets referred. Even BMJ covered this story of how children with leukemia, are treated for arthritis. And this was a very big number in the West 20 years back. But in India, it still continues to be a very, very big number. Arthritis is a common manifestation of cancer. Now, when you talk of JIA, there are some points which are very important. Generally, JIA is diagnosed after longish symptoms, more than 6 weeks. Pain is not very severe. Even paracetamol or mild NSAID will work. There may be morning stiffness, and this pain gets better by the day or with activity. There isn't usually a bone cry or night awakening like typically it happens in children with cancer. The pains are not migratory unless it is a palindromic variant, which is again a very rare variant. And the pain pattern is additive, one joint and then another joint and then another joint. These are the typical features of JIA. Migratory pains, however, are seen in acute rheumatic fever, gonococcal arthritis, Lyme's disease, malignancies. Acute rheumatic fever typically has very severe pain, tenderness, hot joints, swollen joints, and pain is much more than the swelling. And one joint maximum lasts for a week and then the joint pain shifts. Painful arthropathy can also be seen in dengue and chikungunya, and you see much more than what I see. And reactive arthritis is another entity which can be sometimes confusing, but looking at all these patterns helps you to differentiate or suspect leukemia in a patient. History of upper respiratory tract infection, dysuria, loose stools, or a red eye may be a trigger for pain in symmetrical small joints, which can be typical of a reactive arthritis, or asymmetric large joints. So please always ask for these symptoms before you suspect an arthritis is in a patient, and rule out by doing a good bone marrow, a good peripheral smear, an underlying cancer. Cancer with bone and joint pains are not only seen in acute lymphoblastic leukemia, it can also be seen in acute myeloid leukemia, neuroblastomas, Burkitt or B-cell NHLs, Langerhans cell histiocytosis, and bone tumors. And I'll be showing you cases of all these entities. The next is again a case where the patient gets referred to us as a suspected cancer. So this is a child with fever for 3 weeks. The blood culture was negative. There was leukocytosis. But please look at the platelet count. Inflammatory pattern of platelet count. So higher platelet count was there. Neutrophils were present. Again, not very typical of cancer. The ESR was very high. The CRP was very high. Despite antibiotics, this child is not improving. Empirical ATT was given, which is the sad story of our country. Many patients receive this even borderline positive. Grandfather had TB 7 years back. No improvement of fever. Brucella, rickettsia, leptospira, malaria, dengue, everything is negative. Child has moved 3 hospitals and now noticed to have hepatosplenomegaly. CT chest and abdomen is non-specific. Also, the patient complains of mild joint pains now with spike of fever. And at this point of time, when this whole story is going on for 3 weeks, the CBC now shows leukopenia and thrombocytopenia. And the doctor feels, oh my God, this may be cancer. But please look at very interesting pattern. The bloods initially were very inflammatory. You can look at the platelet count, you can look at the TLC count, you can look at the neutrophil count. The ESR was high, which again can be seen in cancer. But now with the progression, the ESR has actually dropped. The CRP has worsened. The child looks sick. And because you want to rule out cancer, a bone marrow is done, and the bone marrow does not show cancer. But when you carefully examine this patient, you find a mild, faint rash with the height of fever. And this rash is also seen in the medial surface of thigh, trunk, and armpits. So that helped us make the diagnosis. And the marrow actually showed hemophagocytosis with very high ferritin. This is typical of systemic onset JIA with the macrophage activation syndrome, which is leading to leukopenia, anemia, thrombocytopenia, and a drop of ESR because of hypofibrinogenemia. So I hope, by taking this detailed history, by looking at these blood pics, you are able to suspect Sogia versus leukemia. And I would say that, doing a marrow whenever you are in doubt is always better, because steroids will be one therapy that will be used for many of these rheumatic conditions. The next case is that of a 4-year-old boy who presents with pallor, low-grade fever, on and on. He's poor eater. He has a milk-based diet. The sad story of many Indian children. And they are bound to have anemia. There is a liver which is 2 centimeters. There is some pallor and cervical nodes. Now the CBC shows anemia. And with that history, with the MCV being low, anybody would be tempted to give iron therapy for this patient and wait for a month or so. But please carefully look at the other things. Typically, iron deficiency anemia has thrombocytosis, whereas in this case, there is a borderline thrombocytopenia. There is a white cell count which comes in the cutoff, but actually it is towards the lower side. The peripheral smear did not show the blast, and the physician was quite happy to treat this child with only hematinics. And that is what was given. But 3 weeks later, this child presents with high fever and severe leukopenia. And what was missing in the initial CBC that was not looked at, I think very important to look at, was the fact that what was the TLC. So when the differential count was looked at, there was neutropenia in this patient. So always whenever we talk of pancytopenia or bicytopenia, we are not looking at the white cell count. We are actually looking at the absolute neutrophil count. That is what is more important, because neutrophils are produced in bone marrow, whereas lymphocytes come from the thymus. So please look at platelet, look at the neutrophil count, look at the hemoglobin, and then only classify a patient as bicyto or pancytopenia. So absolute neutrophil count is a very important marker of an underlying serious illness. An absence of blast does not rule out leukemia. So I hope with these few cases, a common presentation of leukemia is being analyzed by all of you. Otherwise, patients present with hepatosplenomegaly, big lymph nodes. AML can have gum hyperplasia, very typical of acute myeloid leukemia. A painless testicular enlargement can be a leukemic infiltrate. This is very important. Most of the epididymoorchitis or torsion or other illnesses will have a painful enlargement. If there is a painless enlargement, cancer is an important differential diagnosis if you have ruled out hydrocele, hernia, and all the other conditions. So please think of that whenever you see a testicular painless enlargement. Infants can present with skin lesions. This is leukemia cutis in an infant in nursery, and this child had a very aggressive form of a leukemia. This is another child in our nursery who had leukemia, and main presentation was this leukemic infiltration into the skin. Facial palsy can also be one of the manifestations of cancer, especially acute lymphoblastic leukemia, like this girl who had this facial palsy with mild headache, and the doctor thought that this is a Bell's palsy, but did not carefully look at the CBC. We treat Bell's palsy with steroids, and the leukemia also gets better with the steroids. Here, the CBC actually showed that there was anemia. There was neutropenia also in the patient, and the platelet was borderline low. So with the improvement of steroids, the child only presented later to us with very marked thrombocytopenia, again severe leukopenia, but by this time, obvious blasts were present in the peripheral smear. So please remember that before treating any child as Bell's palsy, you are very sure that you are not missing a leukemic infiltrate in the brain. This is another interesting presentation of a 2-year-old girl who presents with fever and gum swelling and redness of mouth to a local doctor. Fever lasted for 6 days, and she saw a couple of doctors and finally was thought of having a Kawasaki disease. Again, Kawasaki diagnosis can be a little confusing at times. She was found to have high ESR, CRP. She was managed with IVIG and steroids. She received 1 unit of blood. She was admitted for 4 to 5 days, and these are all real cases that I'm showing to you. She improved. After that, she had complaints of constipation and was admitted with tummy pain. At that time, she needed injectable drugs. And in January 2022, you can see that this child again presents with fever and gum swelling and poor appetite. Now, if you look at the CBCs here, there is progressive anemia in this patient. Look at the WBC count. It was not too bad earlier, but there is now leukopenia present now. You can see that there is neutropenia in this patient, and the platelet is actually, not too bad in this case. But this neutropenia going on for a very long time in 2019, 2021, 2022 means something. Why does this child have neutropenia all the time? Probably this child had a disease called a congenital neutropenia and now presents with a frank leukemia. And you can see these clubbing in the hand because she was getting repeated infections due to the congenital neutropenia. And never this neutrophil count was looked at carefully. And that was very unfortunate to miss this treatable conditions where GCSF and other conditions can improve the neutrophil count of these patients. The next case is that of a 1.5-year-old boy who presents with complaints of fever and irritability, suspected as viral illness and sent home on oral paracetamol. Now, mother calls after 20 days and says that fever still persists, but bleeding in the eye and swelling of both eyes is present. Now, anytime you see swelling in the eyes, infection is what comes to our mind. Orbital cellulitis. We have one patient right now admitted with this similar condition. But this particular child with these bilateral proptosis, and you can see a little bit of hemorrhage around it, was not just a simple infection. In fact, proptosis is one of the manifestation of cancer. And I'm trying to show you the entire spectrum. There's a huge spectrum of children, of symptoms that children with cancer can present. Now, in this case also, we found leukopenia, and then we identified blasts and bilateral proptosis, hepatosplenomegaly. An important differential that we had was acute myeloid leukemia or a neuroblastoma. So, whenever you see all these symptoms, only proptosis also, do not just empirically treat with orbital cellulitis. Please do a MRI, look for an underlying mass, look for bloods which show definitive infection, evidence of infection, and only then in consultation with a ophthalmologist, these children should be treated, and maybe evidence for pus should be obtained, or if there is a mass, a biopsy should be obtained in these cases. This is AML again presenting as proptosis, and you can see the beautiful improvement after treatment. Rhabdomyosarcoma can present with proptosis of the eye. Langerhans cell histiocytosis can present with proptosis of the eye, and this is another chloroma, which is acute myeloid leukemia. Also, neuroblastoma, retinoblastoma, some of the benign conditions, and obviously orbital cellulitis and IgG disease are other differentials for proptosis in children. Chloromas, which are, deposits of these leukemias, can be present at various areas. They have a greenish hue. Like in this particular girl, we have recently diagnosed this girl, and she actually presented, just a 12-and-a-half-year-old girl, presented with breast lumps. And what she had was leukemia with infiltrates into the breast, which is a very unusual presentation, but chloroma can be present anywhere, and we need to do a biopsy to kind of diagnose this condition. Now I show you another spectrum, rather difficult spectrum of leukemia. This boy is an 18-month-old boy who has a bad, family history with 3 kids dying in the pregnancy. And the child now presents with fever of 1 month. This was the, facial profile of this child when this child came to us because of PUO. And there were many, subtle dysmorphological features like sparse hair, mild coarse facial features, high forehead, down slant of eyes, hypertelorism, and many other features there when this child came to us with PUO. And there was a very big spleen. And that is why a cancer was suspected in this patient, or a storage disorder was suspected in this patient, and was referred to our center. But because of these facial features and this big splenomegaly, we had something in our mind. We performed an echo, and we found a severe pulmonary stenosis in this patient. That helped us clinch the diagnosis. And when we looked at the CBC, there was a very significant amount of monocytosis present. Now, this is very, very typical situation of a child having Noonan syndrome, and Noonan syndrome can have a condition called juvenile myelomonocytic leukemia, JMML, and these children typically present with very significant monocytosis and big splenomegaly. The gestalt diagnosis of hypertelorism, the downward palpable fissure and epicanthic force and ptosis helped us make the correct diagnosis in this patient. JMML has a particular diagnostic criteria, and monocytosis is something that should trigger the thought of a pediatrician towards this diagnosis with the presence of spleen, and there will be absence of blasts like other leukemias. This is another child who is a 2-year-old child who did not have any underlying syndrome, has received multiple courses of antibiotics for PUO. There was a significant spleen again in this patient, and then evaluation for PUO did not, really reveal much clarity. And in fact, one of the very, very prominent hospitals in Delhi could not actually pick the diagnosis of JMML in this patient because there are not many blasts that you see in these conditions. And you see, with this marked leukocytosis, we could identify a significant amount of monocytosis and very few blasts. And the HbF level is very high as compared to, is not very high, is significantly high in these patients. And now we have mutation analysis to confirm the diagnosis for most of these patients with JMML, which is a very difficult disease to treat. Another spectrum of leukemia is this 15-year-old girl who presents with fever, epistaxis, and bruises for 4 days. She has severe bony pains, and there is history of menorrhagia for last 1 month. Very significant bleeding profile. Can you see, epistaxis, bruises, menorrhagia? And this child came from a neighboring city in Delhi. And, for 1 month, she has been treated as puberty menorrhagia and this and that, and has been evaluated for von Willebrand's and many other conditions. The APTT is high, the PT is high, and the child now has some abnormal cells coming up in the blood. A bleeding profile in a child with cytopenias or hyperleukocytosis should trigger something. And that is what we identified: acute promyelocytic leukemia, a very typical type of leukemia where you can have prolonged PT-APTT, and you diagnose this condition with PML-RARA by PCR. Now, this is a translocation that you see in these patients between chromosome 15 and 17. These patients can present with bleeding, they can present with thrombosis, and this condition, if not treated very aggressively, can be very, very life-threatening. And this particular patient can actually have an outcome of more than 80% cure if we diagnose APML at the right time. And really speaking, we are moving towards a chemotherapy-free regimen where we treat these children with atra and arsenic, not even use chemotherapy for most of our patients, and can cure with more than 85% cure. But unfortunately, because of the late diagnosis, by the time this child presented, she had a massive intracranial hemorrhage, and we are not able to save these children. Another important condition is chronic myeloid leukemia. I'm kind of covering the leukemia spectrum and coming towards the end of the leukemia spectrum. Now, CML is rare in children, more common in adults. It can present with a dragging sensation on the left side, early satiety, fatigue, fever, and just a splenomegaly, which has been identified by a pediatrician. There can be bone pains, weight loss, sweating, pruritus, and visual disturbance. And we did report priapism in children with the CML. Unfortunate story came from Haryana and was for 2 months complaining of priapism to various doctors, but was kind of shooed away, and was not really looked at carefully. And by the time he came to us, we could save his life. He's doing very well from CML point of view, but unfortunately has developed impotence because appropriate therapy could not be delivered at the right time. Now, moving on to the next spectrum is the talk on mediastinal masses. So that is again very important presentation feature of children with cancer. Often these children are treated as tuberculosis in our country without getting a definitive diagnosis. They are treated even if cancer is never kept as an important differential for children with mediastinal masses. And I would like to highlight that this is a very important feature for these patients. A little bit of anatomy always helps. The mediastinum is divided into superior, anterior, middle, and posterior. And this really helps us to make the diagnosis. So when you do an anterior X-ray and you find a mass, please also ask for a lateral X-ray, because that can help you define which quadrant of which area of the mediastinum the mass is arising. Now, the children can present with a superior mediastinal syndrome or a superior vena cava syndrome. What is the difference between the two? If the mass is just compressing onto the venous areas, there will be congestion on the face, but there won't be breathing difficulty, there won't be cough, or there won't be, difficulty in lying down. This is usually SMS. Whereas once the respiratory symptoms start appearing and the child has a bad cough or breathing difficulty, or is not able to lie down, it is a superior mediastinal syndrome. What are the causes? The most important cause is a non-Hodgkin lymphoma or a T-cell acute lymphoblastic leukemia. Both these conditions have more than 70 to 80% chance of cure. We need to diagnose them early. Okay, so this is very, very important. Sometimes children with germ cell tumors, mediastinal germ cell tumors, can also present this way. Now, this is a child who is presented with this facial puffiness, and you can appreciate that, he's getting swollen, but again is being treated with anti-tubercular therapy for the last 2.5 weeks with no improvement, and he's just being told that ATT will take a long time for the pleural effusion and the mediastinal nodes to go down. We need to identify where exactly the mass is. So when we talk of anterior mediastinal mass, cancers can be, NHL, leukemia, Hodgkin lymphoma, germ cell tumor. But if you see a mass in the posterior mediastinum where all the nerve roots are going down, you will most likely pick a neuroblastoma or a PNET or a Ewing sarcoma in the posterior mediastinum. And obviously benign masses are there in both anterior and posterior mediastinal mass. So if you see this child anteriorly and you see that there is a mediastinal widening, you're not able to say where exactly the mass is, anterior or posterior mediastinum. So doing a lateral X-ray always helps. This is a typical presentation of a non-Hodgkin lymphoma, a T-cell lymphoblastic lymphoma. A very, very bright student, topper of DPS, presents with this severe breathing difficulty and this huge mass which was coming up. And again, treatment for pneumonia and ATT was what was started a week back for this child. And this is a child where, you can appreciate a mass in the mediastinum, but only when you do a lateral X-ray, you can see the posterior mass, and this is a neuroblastoma. So this is a child, again, with a, lower thoracic mass, and is actually a Ewing sarcoma, which is the Askin tumor arising from the rib cage and going inside into the chest. And you can very well appreciate that on a PET scan. So very, very important to carefully look at these conditions. You can appreciate this again in this large tumor, again, Askin tumor arising from the thorax. Again, 70% cure rate for non-metastatic Ewing's tumor. Moving on to the next case, which is a 9-year-old male child, presents with history of epistaxis, otalgia, and nasal congestion. And now I am going to show you cases which present as lymphadenopathy, because that is also an important spectrum of cancer diagnosis. And many of them, again, are unfortunately treated like tuberculosis whenever you observe big lymph nodes in children. Now, this child interestingly had nasal symptoms, repeated epistaxis, voice was changing, and there were bleeds from the nose, and there was a history of nose picking, but quite significant bleeds from the nose. He was worked up for various bleeding problems and hypertension and all those things, and the neck nodes were really, really prominent. And cancer was never on the cards of the treating doctor. Only luckily, when the X-ray PNS was done, a radiologist suspected that there is something wrong. This needs further evaluation, and a CT scan picked a nasopharyngeal carcinoma in this patient. Now, whenever you see nodes, especially a supraclavicular node, cancer should be very, very high on the cards. We've learned a lot about supraclavicular nodes in adults, but even in pediatrics, neuroblastoma, Hodgkin lymphoma, non-Hodgkin lymphoma, leukemias can all present with neck nodes. And it is very, very important to evaluate carefully a patient whenever lymphadenopathy is present. Now, a lot of symptoms, if you have systemic symptoms, which are the B symptoms, fever, night sweats, weight loss, Hodgkin lymphoma is high on cards. Supraclavicular node, think of cancer. Generalized lymphadenopathy, please think of cancer. I'm sure there are many other infections, but cancer should be one of the DDs whenever you evaluate such a patient, and evaluate the patient thoroughly. Do the bloods, do the ESR, do the LDH, and as soon as possible, try to get a biopsy, because FNAC is really not a very good test when we talk of lymphadenopathy. Hodgkin lymphoma is the biggest player when we talk of lymphadenopathy in children. Usually it presents with like a chronic lymphadenopathy, maybe associated with the B symptoms, commonly seen in cervical area. They have rubbery feel. They are not attached to the deeper structures. Really only they can form sinuses, and mediastinal nodes may be present, but they usually do not cause airway obstruction, unlike the non-Hodgkin lymphoma, where airway obstruction is very, very typical. Now, you have definitions of how to call them positive or negative, but anything above 1 centimeter should be evaluated. And this child is sitting with these big nodes for last 1.5 years. This girl from Bihar came to us with this very bad draining sinus, and is taking tubercular therapy for the last 8 months with hardly any improvement. And very unfortunate that proper biopsies are not done for these children, and lymphomas are missed, where the cure rate is really 80% and above. Now, malignancies and lymphadenopathy, there is a long list, but I would say that lymphomas, leukemias, nasopharyngeal carcinoma, thyroid carcinoma, LCH, neuroblastomas are common disorders that can present like that. So HL and non-Hodgkin lymphoma are different. Hodgkin lymphoma, the nodes are growing slowly. They have rubbery consistency. Matting is not very common. The local temperature is normal. There isn't much tenderness. Epitrochlear nodes and Waldeyer ring is not very commonly involved, and mediastinal nodes are more common. NHL presents with kind of relatively different spectrum, and usually these patients are sick and they have a very short history of presentation. Now, this child, very interestingly, presented to us with autoimmune hemolytic anemia. The DCT was positive, there was severe pallor, and all the other workup was normal for the causes of autoimmune hemolytic anemia, but there was a neck node sitting big neck node, and actually the autoimmune process was being triggered by this Hodgkin lymphoma. Once we biopsied the node, we identified Hodgkin lymphoma, and treatment of Hodgkin lymphoma actually fixed the whole autoimmune process of AIHA also in this patient. Lymphoblastic lymphomas, nasopharyngeal carcinomas, as I mentioned, which is very, very rare, thyroid cancers, and another interesting and rare condition is Rosai-Dorfman syndrome, which is sinus histiocytosis with significant, massive lymphadenopathy. These nodes are slowly growing, and they are not really, very aggressively malignant, but treatment similar to cancer kind of helps these patients. And obviously, we should never forget our friend infectious mononucleosis, which is a common differential, and picking up these typical, these ballerina skirt, atypical lymphocytes in the peripheral smear helps you to diagnose infectious mononucleosis, which is a closed ED for lymphomas. The other spectrum for children with cancer is abdominal mass. I request that, whenever children come to you for vaccination, try and palpate their abdomen. And I understand that crying children can be very difficult to be examined. Never ignore a mother's observation when she says that I can feel something in the tummy, and do not hesitate to call the child back if you're not able to examine the child properly. How do we get good outcomes of cancer? Only patients who have privilege to diagnose children with cancer early can have 90% success of Wilms tumor, whereas many children just present at very, very late stages where the cure rates are dismal. So, we owe it to our patients to pick these soft, subtle signs and treat them aggressively, because conditions like Wilms tumor have more than 90% cure rate. A 6-year-old male presents with a lump in left side of abdomen. And, we always get worried, oh my God, this is cancer and maybe very bad. And you can see this large tumor sitting above the kidney. A suprarenal mass is what else? Most likely it is a neuroblastoma. But lucky for this child, the whole neuroblastoma is a very circumscribed tumor, comes out beautifully. And it is a mature ganglioneuroma variant of a neuroblastoma. And the cure rate is above 95% for these children, and they don't even need chemotherapy. So many of these tumors actually have an excellent outcome only if they are diagnosed at the right time point. And at that young child, now this is an infant. Infants and newborns with large abdominal mass can be neuroblastoma or hepatoblastomas, like in this baby, where there's a massive abdominal distension and there is a massive hepatomegaly, and one would think it's a liver tumor, but in fact it is not. The primary tumor is actually a small neuroblastoma, and it is actually causing a very big reactive, hepatomegaly. The child is tachypnic, there is gross hepatomegaly, and you identify a small adrenal mass, but a very, very large liver in this patient. And you can see the degree of abdominal distension. But with chemotherapy, and we got the urinary VMA, which is very handy and comes quickly, and you can make a diagnosis of neuroblastoma. And with initiation of chemotherapy, even in this dreadfully looking abdomen, this child has an excellent cure rate. And this is very typically seen in neuroblastomas less than 18 months, who have a massive hepatomegaly, skin lesions, and a bone marrow infiltration less than 10%. And their cure rates are very, very, very good. You can see this again, a little baby with skin nodules with these blueberry muffin-like lesions, and again a big liver enlargement, and the child actually had a neuroblastoma. But the other spectrum of neuroblastoma is the sad spectrum, where neuroblastoma at the time of presentation is stage 4, where it has extensive metastasis into the bones. Like you can see this child with bony lesions. He was actually picked up for a severe headache and hypertension, a malignant hypertension, because neuroblastoma was producing all these chemicals leading to hypertension. And the other child with these bony mets, and they can be very, very bad outcome. Now, this is an interesting spectrum of neuroblastoma where the child presents with dancing eye, dancing feet syndrome. It is called opsoclonus myoclonus ataxia syndrome. And this is an autoimmune manifestation of neuroblastoma. And the primary neuroblastoma is actually a very small tumor with a very good outcome. And the autoimmune phenomena generated by this neuroblastoma leads to all this manifestation in these patients. And the cancer outcome is very good, but the neurological outcome may be guarded. With immunotherapy in these patients, you can still have a very good outcome. And often these children are, treated as a neurological disorder for a long time before a neuroblastoma is diagnosed. Raccoon's eye is another manifestation of neuroblastoma and generally indicates a stage 4 neuroblastoma, like you can see in this girl with this orbital swelling, and this PET scan showing an orbital bony metastasis, which indicates a bad disease. I've highlighted the posterior mediastinal presentation of a neuroblastoma, which generally carries a good outcome. And you can see here in the MRI, a posterior mediastinal mass. And in this young girl whom we have just completed treatment, whose mother, kind of picked this lower limb abnormality and paraparetic features, and we could pick this neuroblastoma, quickly treat, and then remove this neuroblastoma, and the child is now walking. And it is really heartening to see this bad cancer going away with the early diagnosis. Neural tumors, sarcomas, Ewing sarcomas, NHL, HL can also present with paraparesis. Neuroblastoma, besides abdominal mass, hypertension, lump in the neck, can also present with chronic diarrhea, which is called Kerner-Morrison syndrome. It can present with Horner syndrome due to the nodes affecting the sympathetic chain. I've highlighted the bony swelling. I've highlighted the bony pains, which is called the Hutchinson syndrome. I've highlighted the opsoclonus myoclonus paraparesis syndrome. And there are some other rare manifestations of neuroblastoma where hypothalamic involvement can lead to obesity, temperature, and behavior fluctuations. So, you can see that one cancer having like 20 presentations, and it can be quite difficult to diagnose. Another important condition in pediatric age group is Burkitt's lymphoma. Now, these children present with an abdominal mass. The mass arises from intestinal area or the peritoneal area, and the lymph nodal mass there can often be treated as tuberculosis because TB is very, very much more common. And because a biopsy is not done and TB treatment is given, this tumor actually divides very, very rapidly. Very aggressive tumor and the fastest growing malignancy in children. But if you diagnose them early, you can prevent tumor lysis, and the cure rate can actually be above 90% for these abdominal masses. The African Burkitt's presents with jaw masses, but the Indian Burkitt's presents with usually a abdominal disease. TB and cancer is the big problem. Almost 30-40% of children who present to us are already on treatment for TB. Abdominal mass, pleural effusion, mediastinal nodes, cervical nodes, bone TB is what is suspected in most of these patients. Another important cancer in pediatric age group, where again we need pediatricians to rapidly pick them, is retinoblastoma. If you identify a white reflex, flash photography is now unfortunately going away. But in flash photography, you can see one red eye and one white eye, and that kind of triggers what is happening in that eye, or a bulging eye, or a newly developed squint should, trigger one to think of retinoblastoma. Again, when children present in this stage, the outcome of retinoblastoma is very guarded. Bony swellings can be bone tumors, often seen in teenagers. Ewing sarcoma, osteosarcoma, unfortunately, in our country are treated as osteomyelitis. The biopsies are not done on time, And empirical treatment as osteomyelitis or TB is given to many patients. If we diagnose them early, refer them early, and do a good biopsy, limb salvage surgery can save the limbs of most of the children with bone tumors. So I think we need to make a diagnosis early. Some of the rare presentations of cancer can be a vaginal mass, like this botryoid tumor, which comes out of the vagina. And this is the photograph which we have taken for one of our patients, where the grandmother caught this mass which popped out of the vagina, and there was extensive bleeding, turned out to be a germ cell tumor. So rhabdomyosarcoma can present like that. There is a long list of vaginal masses, but whenever you see something like that coming out of the vagina of a child, please have cancer as one of the important differential. Sarcomas can also present with soft tissue swellings. They can present with a liver biliary mass, which causes obstructive jaundice. They can present with a paratesticular mass. They can present with an orbital rhabdomyosarcoma, as I highlighted earlier. And they can also present with oral polyps and facial palsy, where a parameningeal location of a rhabdomyosarcoma infiltrates the brain and causes these symptoms. Sometimes children with cancers present with precocious puberties because these tumors produce hormones which lead to accelerated puberty. Commonly, these tumors are ovarian tumors like a granulosa cell tumor, and adrenal tumors, or sometimes even CNS tumors can trigger formation of hormones, and precocious puberty is one of the manifestations of cancer. Germ cell tumor can present with a mass which is there in the sacrococcygeal area. This is a typical sacrococcygeal teratoma. The more it is outside, the more it is benign. The more it is inside, the more chances of it being a malignant. It can also present with testicular, adnexal masses, or a mediastinal mass, or sometimes just a constipation which is not getting better. So whenever you see a patient with constipation and things are not getting better, do an ultrasound and you may see an abdominal mass. And we have picked many patients with neuroblastomas, with germ cell tumors who come with constipation, who were being treated for constipation for a long time, but actually had a cancer. Now, coming towards the end of the spectrum of cancers, LCH is a big mimic. LCH presents with bony swellings, skin rash. It can present with persistent ear discharge, diabetes insipidus, cholestatic jaundice, cystic lung changes, and neurodegenerative changes. This is a child who presented with cholestatic jaundice and had sclerosing cholangitis leading to this manifestation. Lungs can have this moth-eaten appearance. You can see skull nodules like this and lytic lesions. You can see very bad seborrhea, or you can see mild seborrhea. You can see these lungs which are completely, gone and much disproportionate to the rest of the body. And you can just have a very bad lung involvement. And this also child, where this bad skin rash, which was being treated by multiple dermatologists, in fact, turned out to be a LCH. Now, towards the end is brain tumors. And this 16-year-old child who presents to parents, notice not eating well, anorexia worsened. And this child is seen for weight loss and treated like celiac, thought of, endoscopy had ruled it out, and thought of having psychological or psychiatric issues. He's a teenager, he's not eating well. Later, he developed polyuria. He was progressively sleepy, but still no diagnosis was made. Until he had a fainting attack and, an MRI was done to rule out a head injury when a brain tumor was picked up. Similar way, young children can present with recurrent vomiting, headaches, early morning headaches, vomiting, shown to many GPs. And often they are treated for gastrointestinal conditions like GERD or hiatus hernia, H. pylori, gastritis, migraine, functional causes. And in fact, what they have is posterior fossa tumors, which lead to raised intracranial tension. Facial palsy, 6 nerve palsy are the other manifestation. If you pick medulloblastoma early, you can have a very good outcome. Supratentorial and infratentorial tumors have different manifestations based on their locations. And it is very important to kind of take a detailed history to kind of localize from where the brain tumor might be arising and kind of understand how the patient is presenting. Based on the location of the tumor, you can have different presentations of brain tumors, and very high, because some of them can be just non-localizing symptoms like developmental delay, behavior changes, decline in school performance, headaches, vomiting, and some can be actually localizing symptoms like visual changes or optic pathway tumors. Endocrine symptoms again can be manifestations of brain tumors. Children who have syndromes have high chances of cancer. Like children with Down syndrome can present with AML. In newborn period, they can have transient abnormal myelopoiesis, or they can also have ALL. Children with Fanconi anemia can develop leukemia. So keep high index of suspicion when you have a syndromic child with symptoms suggestive of cancer. This child who presents with this eye swelling, careful examination showed many caffeoli spots. He was seen by 4 ophthalmologists, 2 adult oncologists, but the diagnosis was not made. And we eventually diagnosed a plexiform neurofibromatosis, which can be just treated with a targeted tablet. Again, this girl with this nystagmoid movement actually had an optic pathway glioma and underlying neurofibromatosis. And again, the treatment can be started very early in life and can have definitely good outcomes for the life of these patients. So very important to suspect these cases. Now, this child with these tuberous sclerosis, had Shagreen patch and many other, telltale evidence. We identified these tubers in the brain, and only a tablet can actually treat with the targeted therapy many of these conditions. This is WAGR syndrome presenting with a renal mass. Again, a syndrome can help you make the diagnosis of cancer early. So, this is another child who presented with history of recurrent falls, walking issues. Previous sibling also had similar issues. The previous sibling was bedbound and now presents with cytopenias. We identified ataxia telangiectasia leading to a T-cell leukemia in this patient. Again, a good history, and just highlights the varied presentation of cancer in children. So, friends, I've just shown you a huge spectrum of cancer. And why are we doing this? Because we want an early diagnosis of cancer and good outcome of children with cancer. WHO global initiative is to get 60% survival rate for all childhood cancer globally by 2030. And believe me, it's not an easy task. We have picked up, 6 big cancers where we are trying to improve outcomes, but we want every child with cancer to have an early diagnosis to save their lives. A pediatric oncologist alone cannot do all this. We need a big, big team to get a good outcome of children. But what we really need is the support from a pediatrician. Childhood cancer is curable, and it can be done with the attempts of, chapters like PHO chapter, with the support of Indian Academy of Pediatrics, which has always been very supportive of all our initiatives, and with global networks like Iap, for example, which helps get good outcomes of children with cancer. And at individual levels, this was just published today about retinoblastoma, and we wrote this article and the newspaper accepted it. To have early diagnosis of children with cancer, we keep a lot of efforts to sensitize pediatricians to make an early diagnosis of cancer, and that can only be done at a huge multi-level. And this is celebrating life with children who have cancer in our hospital on Christmas. And I thank IAP for giving me this opportunity to take this message forward. Thank you.
Dr. Manas, can you please stop sharing? Yeah. Excellent. I mean, it was absolutely rapid fire kind of a talk. I think you showed us all nearly about, if I don't mistake, at least 40 to 50 cases, which almost covered. Can you just unmute yourself? Which whatever I have seen of far beyond that. I think
I showed like formally 21 cases, but then they were hidden 20 cases along with that to kind of show the entire spectrum of children with cancer.
Maybe apart from Srinivasan sir, all rest collectively must not have seen that many cases. But that was absolutely wonderful. Exactly a kind of a talk that we wanted. But when we see or listen to an interesting talk, it triggers many questions as well. So I'm sure you're going to have a lot of questions here. Maybe I'll take my few questions to start with, and then my colleagues will subsequently take the ones. As I said initially, we always have kind of a stress whether we are missing it early. So many of it, I would say most of the pediatricians are reasonably sensitized for the early pickup, but still there is always a threat. So that's perhaps the reason why many of us over-investigate as well. So you, in your course of the cases, already showed that a CBC can be missing it. So can you tell us which are the subtle things which can be picked up? Grossly, somebody gives a blast sale or something, then it's in a way, it's kind of any blind person can. So if I don't get a blast, then apart from maybe upcoming leukopenia or upcoming platelets, are there any other kind of a subtle clues which you start thinking in case of PU, or maybe some child comes with a fever for 2 weeks? At that point of time, I start thinking of non-localized infection or a connective tissue or a rare leukemia or something
I think,
like
sir,
that.
what is most important is that we look at the neutrophil count and we look at the trend of the platelet count. These are very important markers. If you have done 2-3 serial CBCs, what is happening to the platelet count? What is happening to the white cell count and the neutrophil count? A trend is very, very important. And then please pick the phone and speak to the pathologist. See, this child's fever is not getting better for 2 weeks. Do you think there is something in the peripheral smear? See, what happens most often, these CBCs are outsourced. Somebody sitting in a clinic, you order a CBC, it goes to a lab, you don't even know who's reporting the CBC. So always having a connection with the pathologist who looks at the CBC peripheral smear is very helpful. Iron deficiency anemia typically has thrombocytosis. So if you find anemia with high platelet count, you may be thinking, confirm it with doing a serum ferritin or basic iron studies and ask for a peripheral smear. You will have a diagnosis. If you are thinking of a B12 folic acid deficiency, again, a peripheral smear will help you make a diagnosis. See, even in my hospital, sometimes I have to pick a phone and say, isme hypersegmented neutrophil to nahi hai. And then immediately I get a call, yes, we can find some hypersegmented neutrophil. So, always sometimes, the burden can be huge. There might be junior doctors who are reporting a CBC. Sometimes it is just going at a technician level. Sometimes it is just going at a machine level. So, often there are clues which we are missing. But so I would say, yes.
The flip side of it, if you have a good platelet count, good cell count and hemoglobin, is it having a good, reasonable negative predictive value? If I have a good platelet count,
very good. Sir, I would say that it does have a good negative predictive value. You have 6-7 platelet count, you have 60-70% neutrophil in your peripheral smear. Even if it's a second week of fever, I would not think of leukemia as the first diagnosis. There may be a lymphoma sitting somewhere, neuroblastoma sitting somewhere. You'll have to, by now you would have done an ultrasound, you would have done a chest x-ray in the second week of fever, you would have done some other investigation. So basic investigation profile, infection profile, once you have done, you have looked at the CBC peripheral smear very thoroughly, you have looked at the trends very thoroughly, I think, you'll have to consider all other conditions, rheumatological conditions and many other conditions will be high on your card, definitely. And then, we proceed towards, if the fever doesn't settle, we proceed towards a CT chest or a CT abdomen, and we proceed towards a bone marrow, if we are really into the territory of a PUO. And these are our next line. And by the time you have done a good CT chest, CT abdomen, you have done a bone marrow, and you cannot find anything else where, again, rheumatological condition or a rare infection or brucellosis or something which is, kind of hidden may be one of your important triggers. And we have identified TB in the bone marrow. We have identified brucella in the bone marrow. We have identified Kala-Azar in the bone marrow. So, not only for cancer, for many other conditions, such investigations are helpful.
In this strongly suspected case, once I go to CT normal, bone marrow, suppose normal, does it rule out leukemia? My first bone marrow, normal, does it rule out leukemia?
Sir, in our country, a big problem is steroid pre-treatment. That is a very big problem. Now, in this COVID era, We have seen so many children treated as MISC. So many leukemias were treated like MISC because COVID antibody was high. Now COVID antibody is high in every child now because everybody has had COVID. So that COVID MISC became a very important reason for us to have missed leukemia. So, juvenile idiopathic arthritis is a very, very important differential for us. And our rheumatologists, before giving steroids, would always get a marrow done because the picture can be confusing. So if your marrow is negative, we have had difficulties in picking leukemias in such children. But if they have not got steroids, more or less, we are able to pick leukemia. In majority of the cases, some of the AMLs can be difficult. But again, we do cytogenetics. We have other ways of picking AML if the blast count is not very high.
No, my question is slightly different, Dr. Manas.
Okay,
if it is genuinely treated patient, I'm sure, or is being treated by myself right from first day of fever, I'm sure there is no steroid received. And at the end, in this suspected case of maybe low count and all, I do a bone marrow, and bone marrow don't show me blast. Do I rule out? Or you'll end up with something which may be shown in the second or third?
You can fairly rule out a leukemia. Very rare forms of leukemia like JMML, I showed, only monocytosis, not much of blast. Rare forms of leukemia like chloromas, where, marrow is not much involved, but there is a chloroma sitting somewhere else, or the marrow involvement is very less. These are rare forms. Generally, most of the cases you will not miss if you have done a marrow properly.
And when you are saying bone marrow, you're talking about only aspirate or a biopsy as well in every case?
So, for biopsy is really important for aplastic anemia. You have a child with pancytopenia. You don't know if it is leukemia or if it is aplastic anemia. You have a very obvious leukemia. You are doing a bone marrow. You don't need to do a bone marrow biopsy. But when you are talking of pancytopenia and not much of organomegaly, suppose you have a 5 centimeter spleen and a pancytopenia, again, chance of aplastic anemia is not there. They will not have organomegaly. So, when bone marrow biopsy is very essential when there is aplastic anemia. For leukemia, if you get a good aspirate, good, flow cytometry and all the other markers, you don't need a biopsy. Now, sometimes when children come with steroid pre-treated, the bone marrow aspirate is not enough. We do a biopsy because we can find cluster of blasts. And we can put immunohistochemistry marker on those clusters and we can make a diagnosis of leukemia then. So in those cases, we go ahead and do a biopsy.
Rajendra, Chetan, Narmada,
please take your questions. Single dose of steroid also will change the whole scenario, sir?
Sir, now it is very difficult to say, but there are some extremely sensitive leukemias where even one hydrocortisone as a pre-med before transfusion can actually make the leukemia disappear. Generally not, but yes, we have seen cases where even 1 or 2 doses have made a huge difference.
Sir, what is the transfusion change it? Relevant to that, how does a transfusion, I get a severe anemia patient, then I have to send it and it's a Saturday, I can't send it to a cancer center and I have to stabilize.
Transfusion does not change leukemia. Transfusion does not change bone marrow. What transfusion changes is, in a hemolytic anemia to do a HPLC before transfusion because you want to make a diagnosis of thalassemia. In a Fanconi anemia, you want to do a chromosomal breakage study before giving transfusion. So these are 2 conditions where transfusion changes. It doesn't change aplastic anemia bone marrow. It doesn't change leukemia bone marrow. So if you have leukemia and a child is almost in CCF, please give blood transfusion and then refer the patient. Please give platelet transfusion and then refer the patient, but avoid steroids.
Rajendra, please.
Sir, what is in adult, what is the role of LDH in pediatric malignancy?
So, sir, it is a non-specific mark. So in cases, especially in cases of Burkitt's, non-Hodgkin lymphomas, where the tumor proliferation is very, very rapid, the LDH is very high. Now, having said that, even in ALL, AML, we have seen very high LDH. So it is not diagnostic. Once you have a diagnosis of, say, Burkitt's, LDH is used for prognostication or for therapy allocation. But it is again, something which can be easily done in the periphery and can give you an index of suspicion. But it is non-specific.
Sir, as a general pediatrician, normally we say that we get a rare cases, but in Kikuchi or in Alps, how much is the probability of going? So what a pediatrician should monitor?
So very important. I deleted those slides because the presentation was becoming huge. So Kikuchi, painful cervical nodes in the posterior area are Kikuchi. Again, you want to be sure of cancer, that you're not missing cancer, you need to biopsy it. It shows Kikuchi, you just treat with steroids and anti-inflammatories and all those things, So it is an important differential. It is, and usually you will have inflammatory bloods in these conditions. ALPS is a difficult diagnosis. ALPS is usually a chronic lymphadenopathy, a chronic splenomegaly, now presenting with autoimmune manifestations. And they can evolve into lymphomas.
Yeah.
So again, it's a very difficult diagnosis, a good history, a good lab, doing double negative T cells. It can be a little challenging.
And last question from my side. In short, can you give something about the tumor lysis syndrome? I mean,
Yes.
little emergency.
So very briefly. So I have done this talk, I think, with the DIAP platform. I'm not sure. I think with the PICU friends of I did on oncologic emergencies. So tumor lysis is because the cells die very quickly. They are highly sensitive to treatment, the cancer cells. And once they break down, either spontaneously or with treatment, they lead to release of potassium. They lead to kidney injury. There can be hypocalcemia and hyperphosphatemia. And this can be life-threatening. Usually children with ALL and Burkitt are the most common cases. ALL with white cell count above 1 lakh, and any Burkitt patient will have a very high tumor load, and they will the cells will quickly die and cause acute kidney injuries. So give lots and lots of fluids, avoid potassium containing fluids, give them allopurinol because uric acid is high. And if the uric acid is very high, give them raspberry acid.
Thank you, sir.
Chetan?
Hi, Manas. Excellent talk. You covered everything, almost everything. Now the question is, as a pediatrician, I would like to know which are the cancers which we should not be missing, because the early diagnosis, it is really life-saving and a best outcome. So just few cancers where we should be, early diagnosis will be very fruitful.
Sir, I definitely agree. Some of the cancers that I have described are very difficult to pick or diagnose. But what you can pick in your clinic is, high index of suspicion for PUO, leukemia, a mediastinal mass, not to treat as TB, pleural effusion, not to treat as TB unless you have evidence. Okay, an abdominal mass, which you can palpate during your vaccination visit, and pick up, or just when mother says there is something, and then you give time, you have to give pedicloral, you have to do whatever to palpate that abdomen. You have to palpate it or get an ultrasound done to make sure you have picked that. So I would say lymphadenopathy. So many children are being treated as empirical ATT for lymphadenopathy who have Hodgkin, and then they come at stage 4 where the outcome goes down. I think these are some of the common cancers that, flashing a light into the eye. I think, these are some things which we need to, we owe it to our families. And I can understand, acknowledge that in busy clinics, we miss that. But I think sensitization is very important, so that when somebody comes and reports to you, at least we don't miss it then.
Neuroblastoma, sir. Gait abnormality, and we have picked 2-3 cases. Just gait abnormality, and then we refer to neurologists and they picked up.
Back pain. Many children with cancer present with back pain. And often वो school bag की वजह से होगा, या other reasons, posture, TV बहुत देखता है, all those reasons are given. But again, I think we need to look at these children carefully.
CNS tumors also fool us a lot. Sometimes what happens early morning, you said vomiting, and child, when it comes to us, it is playful jumping from chair. Absolutely no clue whatsoever, and ultimately we go for vomiting. We go for GI investigation. Finally, we come to know.
Absolutely. Most of these children are under gastroenterology care, and many of them have undergone endoscopies.
Yes.
And this is a genuine problem, because a headache in a child is not very, it's just the irritability. It's just the lack of interest and the lack of appetite, and the child just becomes disinterested. which kind of, later tells us that it is a brain tumor.
So early morning headache and vomiting has to be investigated for sure. I have seen one case and then I never take a chance.
Yes, sir.
Maybe you overtreat it, but we get it.
Yes.
Just one thing about just now Rajendra said about the neuroblastoma. I always believe that's the most challenging cases to diagnose because I have got extremely varied presentation. Now, of all the investigations available to you, when there is no definitive mass, clinically appreciated or other kind of a email, because it could be a small kind of a growth in the adrenal which will trigger it. Now, which is the most sensitive and specific
Sir,
test
we try to
rule out?
screen with the ultrasound and the X-ray. And if neuroblastoma is high on cards, we go ahead and do a CECT chest and abdomen or a PET CT. Okay, and MIBG scan is ideal, but again, MIBG availability is a big challenge. So young children, because neuroblastoma comes in very young age group. Again, all these, I showed 15 presentations of neuroblastoma, one disease and 15 manifestations of neuroblastoma. It can be a big mimic, very big mimic. But again, sir, with a good ultrasound, X-ray, I would say we are able to pick 90% of the cases.
In your whole
Any
presentation,
cutoff for
yeah, go ahead, Rajesh.
any cutoff for PET cancer in pediatric age?
No, sir, we can do it even for newborn.
Okay.
Now, in your presentation, you made some sensational comments in few of the cases. So one, FNS is useless. Is there any role of FNS in pediatrics?
I didn't say FNAC is useless.
I won't say.
I said FNAC, the benefit of FNAC is gone down significantly. What happens in FNAC and you get a reactive report and you forget about cancer. The problem is that if you get a positive report in FNAC, you know that, okay, you have clearly seen tuberculosis or you are very sure and everything. It's okay. Then you don't have to, go back and evaluate it. But when you are getting a negative report in a significant node, what are we going to tell the family? Oh, ye cancer nahi hai. But you have only done a fine needle aspiration and the cancer may be patchy. So you need to see the whole anatomy. So the role of FNAC is actually gone down significantly for making a cancer diagnosis only if the biopsy is, impossible. You have a node sitting in the lower down in the jejunum area and you are going by the endoscope and you are trying to get something and then you are having a fine needle. Those are the extreme situations. Or sometimes, we are doing FNAC to kind of, we know that this is TB, we just want to prove it. And we have proved it. But then when you get a negative report and to sit on that negative report and, ignore the symptom is not a right thing.
Second is, we always think there is some timeline for a disease. Say virus beyond 7 weeks, 7 days not likely. Connective tissue maybe up to 3 months. Similarly, is there any timeline to negate a diagnosis? You showed one case when the lymph node was there for 1.5 years.
Yes, sir. Yes.
And you
Hodgkin lymphoma, I have seen Hodgkin lymphoma 1.5 years, 2 years Hodgkin lymphoma I have seen patients, sir.
Yeah. So apart from Hodgkin's, other ones, where is the timeline?
Low-grade gliomas, brain tumors, low-grade gliomas.
Okay.
You can have a very longish history. And it is one of the WHO cancers where we want to get target those tumors. So, these are slowly growing tumors. Generally, most of the malignant tumors are aggressive and they will present within, say, maximum 2-3 months would be the history.
So
now, bone tumors again.
I'm sorry. Please.
No, so bone tumors is again one condition where, there can be a longish history and, we have heard of stories of 3-4 mahine se bachche ki tang suji hui hai and he's being on ATT or osteomyelitis treatment. And no biopsy has been done.
Why I'm asking you is the cervical lymph nodes they come with, sir, ye gaad to 6 mahine se padi hai. And na hi बढ़ रही है ना ही कम हो रही है. Fever nahi hai, kuch nahi hai. Should I get it out?
Yes, sir. If they are significant, you have to evaluate them. You can't ignore a big cervical lymph node sitting in the neck. It can be Hodgkin. We have all the time seen without B symptoms. Children just with a big node, 3 centimeter node sitting for last 6 months turns out to be Hodgkin lymphoma when the child starts having PUO.
Yeah, one more case you showed was autoimmune hemolytic anemia, and we do see them quite often, and we don't know the exact cause. Now, do we go for bone marrow of each of them?
So we never do bone marrow for autoimmune hemolytic anemia. So hemolytic anemias typically don't need a bone marrow, because what you will see in the bone marrow, there will be increased erythropoiesis. Only that. CDA is one bone marrow where one hemolytic anemia where bone marrow helps you to make a diagnosis, because you see that lot of dyserythropoiesis and nuclear changes and all that. Hemolytic anemia generally we don't need. In autoimmune hemolytic anemia, AIHA, most of the AIHA in children are primary AIHA. Or there may be, conditions like lupus or some mycoplasma, EBV virus, CMV virus. So generally a good examination, a good history, there is no preceding problem, a sudden onset of a hemolysis in a child, that kind of tells you that this is what it is. And we don't go ahead and do marrows or do a CT chest or CT abdomen. If there is a suspicion, we screen them with an X-ray and an ultrasound.
Maybe last question from my side. Congenital malignancies, how common they are, and when do recently I came across a child who at birth was sent to us and kept on vomiting for almost 8 days, and everything came negative, including the CT abdomen. We thought it could be obstruction, but nothing, no malrotation, dye study, CT, everything normal. Discharge after 1.5 months, she came again with obstructive symptom, and now the CT showed a massive mass, which turned out to be a spindle cell carcinoma. Now, how do you think I could have picked up this in early phase?
So, sir, neonatal malignancies are very rare. They are often treated like sepsis or other conditions, because to pick them is difficult. I would say that many of them, like neuroblastoma or these are not that bad. Some of the congenital tumors are not that bad, and they can be managed. Congenital leukemias are unfortunately very aggressive. Their outcomes are bad. And if you have Down syndrome and you have high white cell count, then again, transient abnormal myelopoiesis is one important differential. So, these are difficult areas, and I would say that only a high index of suspicion and a good investigation profile will help you make a diagnosis. And obviously, you'll be ruling out all your other conditions.
Rajendra, you have any questions?
Yes, sir. Regarding, you told that supraclavicular node is a high suspicion of malignancy rule out. Is there like mediastinal mass? If it is a posterior, anterior, so posterior we have to be a little more aggressive for ruling out malignancy, or it's not like that?
No, sir, it's not like that. In fact, posterior neuroblastomas are actually good. Their behavior is good. Their outcome is also better. So any mediastinal mass, you'll have to be aggressive. The anterior mediastinal mass present very rapidly because they are lymphomas. They grow very rapidly. They don't give you time. So you need to have very early referral. Sometimes in dying patient, your friend is calling and, the patient is dying. We have given steroids without making a diagnosis. In consultation with the pediatric oncologist, we have given steroids empirically to save the life of the child. Because if this mass disappears after giving steroids and the child starts breathing normally, the only diagnosis is a T cell or a B cell leukemia or a lymphoma. That is the only diagnosis where a child with a mediastinal mass improves the next day and is able to breathe, who was about to die. Because intubating these children, sedating these children can be very, very dangerous. Again, that comes into the whole oncologic emergency discussion, but both have to be addressed aggressively. The anterior ones present more dramatically, I would say.
Oh, thank you, sir.
Srinivasan,
So
sir,
one question, Dr. Manas.
Yeah, please. Yeah.
Like you said, Hodgkin's disease mass is a challenge, and in that case, if we don't have a tissue for diagnosis, like a child.
Dr. Sandhya, your voice is breaking.
Maybe sir signals. So mediastinal mass may be a restriction for the excision biopsy. Anesthesia may not be possible. What should be the approach in that case?
So, ma'am, if you have a peripheral mass, you would biopsy that. You will not go into the mediastinal mass. But if you have no other nodes anywhere, then a interventional radiology guided true cut biopsy from a mediastinal mass can help you make a diagnosis. We don't want to excise Hodgkin lymphoma or a non-Hodgkin lymphoma because that would be too aggressive. Sometimes, you have a mediastinal mass and you have abnormality in CBC, we make the diagnosis from a bone marrow. Sometimes you have a pleural effusion, we take the pleural effusion out, we see there are malignant cells, we make a cell block and we make a diagnosis from the pleural effusion. Now, suppose
flow will be helpful if we get a tissue.
He lost connection. Dr. Manas is not there. He lost his connection. He lost connection. He's not there.
She wanted my comments, sir.
Definitely.
Talk.
Please,
It was a wonderful talk, and of course, as Amdekar always says, keep neoplasm and this thing, cancer as one of the important possibilities in every case. That is how, and steroid use, misuse should be avoided not to miss that. And we have seen some cases like that. And of course, there have been instances where postgraduates have done meticulous examination and epitrochlear lymph node, and then this thing, with anemia, turned out to be Hodgkin's disease on this thing. Similarly, Horner syndrome presenting with a cervical lymph node and this thing, especially left supraclavicular lymph node. So there have been instances, and I still remember one postgraduate doing an examination, sensory system examination of fifth nerve, and we found that, corneal reflex was absent, but other this thing was there because spinothalamic tract, sensory is very long. So that turned out to be a tumor in the upper pons, this thing area. And child was referred. Those days we didn't have facilities, so we have to refer to neurology center in ICH. I think I have mentioned in the Pearls, which you had asked me to give. So sometimes, some postgraduates, they have meticulous examination. Similarly, I told you in the previous one, we had a child with tetralogy fellow. Child had this thing, hematuria, renal vein thrombosis. I thought immediately I took the child to do ultrasound upstairs, and it turned out to be Wilms tumor. And then they said, we cannot operate on tetralogy fellow. Wilms tumor has to be treated first. And finally, unfortunately, that patient died of Wilms tumor because they came in a long stage. Because hematuria is the right manifestation of Wilms tumor. So it's very important that we always keep in mind the possibility of malignancy and avoid use of steroids, etc. Whenever there is a pressure effect on nerves, etc., we must think of that possibility also. Any lymph node in unusual site like epitrochlear and this thing, where there is no skin manifestation causing that, or scabies or some other reason. Thank you, sir.
Thank you very much, sir. Dr. Manas, you are making some comment on Dr. Sandhya's question about the Hodgkin's lymph node and the tissue.
Yeah, so I just said that, mediastinal biopsy is our last resort. We try to do periphery, we try to do bone marrow, we try to do pleural fluid. Sometimes beta HCG AFP gives you a diagnosis of a mediastinal germ cell tumor. Just a simple blood test. So, we have all these methods of making a diagnosis. If we are not able to find anywhere, then we go do a true cut biopsy from the mediastinal mass.
You have seen any paraneuroplastic syndrome in children, sir?
Sir, that again was part of my talk, but I had
how is
to
the
delete
incidence
it
of skin malignancy?
Because the number of slides were just
no. I know that. Yeah, you have covered almost.
So rarely paraneoplastic syndrome can present as cancer. We have seen Hodgkin lymphoma presenting with total neurological symptoms. Opsoclonus myoclonus, one of the manifestations, and many others. There are many other manifestations of hypercalcemia and many other paraneoplastic manifestations of cancer. Rare, yes, sir. Rare.
Just one thing I wanted to say about your mass in the mediastinum. Perhaps endobronchial ultrasound is coming in a good way now, and that can be a good method and safe method to get the mass and diagnosis. Yeah.
Yes, sir. Whenever we feel that it may be difficult to approach outside, we do a EBUS. And with the help of EBUS also, we are able to make the diagnosis. And the IR team and the EBUS team talks to each other, and they say, for this particular patient, what is the best way to get a diagnosis?
Absolutely. Dr. Nilima?
Sir, is it important to get diagnosis of genetics? Once we diagnose some type of cancer like leukemia, is it important to find out the genetic?
Very important question. Now, there are some clues in every case which point towards the genetic origin of a tumor. That means genetics coming from parents or the child's genetics. Okay. Then the second genetics is the genetic of that cancer cell. So like in leukemia, for every leukemia, we do a cytogenetics, we do molecular studies. Those are the genetics of that cancer cell. Those are not the genetics of that patient. But there are some cases where, we suspect, okay, this may be a Down syndrome, this may be Noonan syndrome, there may be a Lee-From-Any syndrome, there may be ataxia telangiectasia, there may be Fanconi anemia, there may be, all these cancer, malignant rhabdoid tumor predisposition syndrome. There are many, many tumors. And now we are, with the immunodeficiency field improving so much, many of the non-Hodgkin lymphoma have an underlying immunodeficiency. So we are able to pick all these cancers because now we are becoming smarter with the day, and the labs are also available. NGS is available and all. So I would not say for every child with cancer. So suppose you see an adrenocortical carcinoma, you need to evaluate for Lee-From-Any. You see a very heavy family history of cancer, then you need to look for cancer predisposition. A myeloid leukemia in a newborn, you think of AML, or you think of Down syndrome. So, there are some markers and some particular tumors where, we would be more aggressive. So caffeoli spot present and a cancer means you will look for a cancer predisposition. Hemi-hypertrophy and cancer means you look for a genetic concern. Some mental retardation, Wilms tumor, you will look at WGI. So, there are telltale signs, but not for every child, In fact, most of the children, we will not go for a genetic concern.
Sir, how is the incidence of skin malignancy in your experience in pediatrics?
So, sir, not much. Skin cancers are usually, skin tumors would be like a leukemia cutis. So it's a myeloid leukemia coming into the skin, or it may be like a sweet syndrome. It might be neuroblastoma coming into the skin. So LCH coming into the skin. So they are not per se skin malignancies.
Melanomas?
Indians, we have a lot of melanin, so we are fine. We are not like the Western people who have, very high incidence of skin cancer.
Thank you.
I think we have exhausted our questions as well. It was absolutely wonderful talk. In a long time, we again got another very nice talk here. And the last talk, as you said, we had that emergencies in oncology. That was our own chapter, pediatric critical care chapter. We have archived that on our website as well. It's freely available for all of them to revisit, and a lot of re-hits on that talk. Amazing talk again. Thank you very much, Dr. Manas.
The credit goes to the team of experts who picked up such a wonderful speaker.
None
of the academic pearls has failed to deliver the goods.
In a modern language, you can
Thank
say
you, Dr. Mahesh.
Thank you, sir.
Thank you all of you.
Basically, there are few faculty who are on our hit list always. So Dr. Manas is always there to get the best information. So thank you very much, Dr. Manas, for sparing your most valuable time. Dr. Upendra could not join because, as I said, he's in the flight, but he would have loved to be here. So thank you, Dr. Upendra, for really allowing this such a wonderful series. And thank you all my conveners and the team of DIP, Rajendra, Nilima, who's working so hard to make the life kind of comfortable for us. Narmada this time joined, and wonderful things. Chetan was there till this time. Thank you all my colleagues for being here. I request
Dr. Manas, take it to every district hospitals and train all the practitioners, pediatric practitioners.
Over to Nilima for announcing next week's talk, next week's program, please.
Thank you, Dr. Manas. It was a wonderful session, eye-opener, I can say. And now we are continuing with the hematology session in next week also. We have mentor-mentee session next Tuesday, hematology updates. Mentor is Dr. Anupam Sachdev, and 3 mentee, Dr. Shraddha Chandak will be talking on autoimmune hemolysis. Dr. Siddharth will be talking on thalassemia, and Dr. Preetham on sickle cell disease. So see you all next week. Thank you.
Thank you all.
Thank you, sir.
Srinivasan, sir. Thank you very much for joining.
Thank you very much.
Thank you very much.
Pleasure listening to each and every one of them. Thank you very much.
Thank you, sir. Thank you very much. Thank you.